Okay. So as I'm Marvin Malik, I'm one of the preceptors for the Northern New England Health Policy Internship Program, and we're going to revisit Medicaid right now. Um, we introduced the topic last week, and the Medicaid program was formulated out of the deficiencies in the protests from the late 1950s and early 60s, when the employment-based healthcare system, which had evolved during the New Deal and then the Eisenhower era, uh, basically left out the poor and the elderly. And with a progressive Congress and with a progressive Congress, Lyndon Johnson, the president in the mid 60s, was able to enact two very major programs to provide care for the elderly and the poor. The program for the elderly was Medicare, which is not the subject of today's discussion. The program and Medicare is federally administered, while the program designed to provide health coverage for the impoverished population in the United States was called Medicaid, and it is administered at the state level. Eligibility for the program, as would be clear from what I said, is tied to income and also to the extent your wealth. And those criteria change pretty frequently. In some states, you can own a house, but not too big a house, not too expensive a house. And then you can also become eligible if you become disabled. The benefit package is very comprehensive. Uh, in most states, there are not co-pays. There has been some experimentation over the decades in some states to give very small co-pays, in particular for medications, on the order of $1 to $5. That's happened over the years. Some of the states have transportation benefits, especially if you're pregnant or in sometimes other high-risk groups. And then dental care for children is covered, and some dental care or much dental care for adults, but you wouldn't get an implant, for instance. So eligibility for kids is very, very heavily affected by individual states. And in general, the states, they have to provide an absolute minimum. If you are earning 99% of the federal poverty level, you are in every state. But the federal poverty level is pretty damn impoverished. And many states provide Medicaid for somewhat higher income, particularly for children who are in families that have higher incomes. So in Vermont, where I live, for instance, they initiated a program called Dr. Dinosaur, and they took advantage of absolutely every Medicaid dollar that they could. In 1997, or plus or minus a year, during the Clinton administration, they added on a program called CHIP that various people have mentioned, Child Health Insurance Program. And that added on a lot more kids to get coverage. It's basically a kind of Medicaid expansion toward children. And the states were allowed to even take it all the way up to 380% of poverty. And in Vermont, we've done that, and so as they have in Massachusetts and I think New York, probably Minnesota, and several other states. Uh, None of them are located south of the Mason-Dixon line. And we'll add um, eligibility for kids and parents for the child's first year of life can extend above the poverty level. In other words, um, if women who are pregnant will don't have to be so impoverished to qualify, but some states can really make that pretty minimal. And as soon as the child turns 1 year old, then that woman might lose her coverage. And in some states, I don't think all of them, the other parent, might get covered, but that varies a lot by states. And then later, we're going to talk about managed care. 41 out of the 50 states are shoving Medicaid patients into managed care without their consent. So we compared Vermont, which has a generous Medicaid program, even though we're not nearly as poor as Mississippi is, where as at least for adults, they cover considerably a smaller percentage of their population. Um, so we went over that last week. That the other another feature of most states' Medicaid programs is that it got expanded from eligibility at 100% of poverty up to 133% of poverty uh, through an important part of the ACA, the Obamacare legislation. But the Supreme Court decided that the states could elect not to participate. So there's still 10 states, Wisconsin and several the other states I think are in the South, maybe Arizona, I'm not sure about that one. Anyway, that have not elected to expand Medicaid eligibility up from 100% of poverty up to 133%, even though the federal government, the structure of the program is the federal government would pay 100% of that for the first 3 years, and thereafter the government would pay 90%. For the regular Medicaid program, there is also a federal match. So if in Vermont's case, it's 56%. So if Vermont spends $44 on their Medicaid program, the federal government gives us $56. Now, and in case of Mississippi, Mississippi only has to spend $28 to get $72 from the federal government. So they're getting a better deal, and that's because they have a much poorer population, many more impoverished people as a percentage of their population compared to Vermont. So, and then once they get to 100% of poverty, if they would have gone along with the Medicaid expansion, they would have gotten the 90% and 100%, as I just mentioned. So, but Mississippi refused to get involved with that so far to go along with the Medicaid expansion, so they don't have that, and consequently, many individuals say they're at 120% of poverty and they need to be hospitalized. That hospital may try to transfer them to a different hospital. It's a safety net hospital that takes care of poor people, of which that's an especially prominent feature in Louisiana and Texas, to have safety net hospitals. Some hospitals take care of poor people, other hospitals don't. So that leads to an income-based sort of segregated system. But anyway, but what that means is that the hospital who is taking care of that person who's at 120% of poverty, when they start sending out bills, they're all going to go to the patient. And the person's really poor. They're only earning 120% of poverty level. So as you can imagine, the patient's going to end up with a ruined credit score, and the hospital is going to likely end up without any revenue because there's no possible way a patient can pay for fees when they're that poor. So what the implication of a very stingy Medicaid program is that their hospital infrastructure and other providers will have less money. They'll have less funds to work with to keep their hospital functioning well. It's really, well, you can draw your own conclusions, but it's in many ways self-destructive, and the hospitals and other elements of the healthcare infrastructure in those states is certainly not happy about with what their government's done. So as you'd also imagine, there's a lot of lobbying that goes on to try to get them to at least take the Medicaid expansion. So you can see the proportion of the population covered through Medicaid depends on the state government's attitude toward getting their population covered. In Vermont and California, really, these are not the poorest states in the country, neither is New York, but there's been a government that's wanted to get as many people covered as possible. And Alaska's done so as well. They're a red state, but they've decided they want to get their people insured. And so they've participated in these programs to try to bring as many people into coverage any way they can. And so this map, if you look at it, especially all the 6 southeastern states, so the black shading means they've got a higher percentage of their population in the Medicaid program. And the lightest blue shading means they have the least. So especially if you look at the lower right-hand corner there, these are states that don't have a particularly high percentage of their population in the Medicaid program. These are not wealthy states. There's a lot of poor people in South Carolina, Tennessee, and this graph shows you the percentage of the population that's extremely poor. So now you can see that Vermont's dropped out of that. We don't have that many impoverished people compared to some other states. But those southeastern states, Florida, Georgia, South Carolina, Alabama, they do have a lot of really poor people, but those governments in those states have not elected to get every single person they possibly can insured through the Medicaid program, which gets them federal money through the match and which gets more of their very poor people covered. These are people who generally would have a whole lot of trouble accessing care. So this is how the priorities of their governments have elected to behave. By the way, Louisiana is a little bit of an exception. They have tried. It's a very poor state, and they've taken advantage of more Medicaid money than many of the other southeastern states. And they need to because it's a very, very poor state compared to the others. So feel free to stop me. Any questions so far?
Dr. Malik, yes, I had a question because I'm still a little confused as to what exactly is the incentive for these governors to not take the expansion from the federal government, other than just like politically them saying we don't want to work with the Affordable Care Act and we don't, we don't want to, yeah, exactly. I don't understand what are they telling their constituents is the reason why they're not agreeing to the expansion.
Compared to other developed countries, there is an ideologically based aversion to socialism, big government programs. Those who oppose big government programs are particularly averse to successful ones, because successful government programs make an impression on people. Like if you say, we're going to start, hey, aren't you excited? We're going to have a whole new government program in Vermont. And the average American, not just in Vermont, but especially elsewhere, will say, yeah, well, that's going to really work. It'll be a big bureaucratic mess. That's what you're supposed to think and say, that big government is inefficient, so we should avoid it. So my belief is that the logic is ideologically based because I frankly can't come up with a policy reason. So in Mississippi, they would have to spend the 28 cents out of every dollar. If they don't believe in big government, then they don't want to do that. They're certainly harming their infrastructure and harming the health of their populations. I can't justify it, Nehemiah. Maybe there's some way we could try to talk to someone in those states. I can do a little bit of outreach. I'll have a little more time starting tomorrow, and I can see if I can find someone from Mississippi in some of those other states to provide that rationale.
And I'll just throw out, just as looking for the other sides, what I would anticipate they would say is, just as we are saying it is unfair for rich people to tell poor people, you should eat better, you should exercise more, you'd have better health incomes. These states are a much poor, like Vermont and Mississippi, the other obvious difference, there's a lot of differences between them. Vermont is much wealthier per capita than Mississippi. And so spending more money even for something, I mean, I think that's their response would somewhat be is they're different situations. And I don't think it's a great thing. I think ideologically it drives so much, but I do think there's a difference in wealth between a lot of these countries a lot of these states that we're looking at.
Let me comment on that.
Yeah.
That's true for New York and California, which both have a lot of rich people. But Connecticut and Vermont, which both have progressive governments, there's a real different situation. Connecticut has a lot of rich people, and Vermont is a little unique. Vermont and Maine are poorer than the rest of New England, and in particular, we lack really rich people. We don't have Wall Street here, and there's a little bit of backlash going on in Vermont because to get the funds to have big government programs, we've had to tax the upper middle class to a greater extent than Connecticut or New York would have to. So Vermont's not the wealthiest state, but we've had a progressive government because I really truly believe this, but there is an ethic of social solidarity in Vermont that maybe to a greater extent than most any other state. Like we really care about each other, and we don't like the idea of people who can't get coverage and who can't access the doctor. It's just unacceptable. We had the most vigorous response to the COVID pandemic where people were not arguing when we had, when we were on restrictions and had to wear masks and had to not go out. We have a Republican governor who enacted all of it. Fabulous policies on COVID. So there is a little bit of a different ethic, but I think it can change elsewhere. So when I say that, I'm basically talking as a percentage of the population. And I think that ethic can change over time in a progressive, favorable manner throughout the whole country. My niece, who was just visiting, lives in Nashville, and I can tell you that Nashville is extremely progressive, and that progressivity is not confined to the city itself. But it's not the majority of Tennessee. So even though there are many progressive people in Tennessee, they're not a large enough proportion of the population yet to change and get Tennessee to take the Medicaid expansion and enact some other policies that involve more social solidarity. And I want to say something else. I actually think that the people are influenced by leadership. And I think because of national leadership, bullying and machismo are more acceptable to much more of the population now, being kind of macho and insensitive. And I think that's in response to leadership that the ethic of the population has changed. And I personally think that bullying is harmful to children and other human beings, and that I think it's important for those of you, I hope you all become leaders, and I would like you to be role models to oppose bullying, to show people that you're kind. And you are a role model. Keep that in your mind, that the way you behave in public really makes a difference. And other people, will see you as role models to varying extents. So I think we've had leadership that at a personal level has not been a good role model. For those of you, I don't know if those of you noticed, but if you have a way to listen to Michelle Obama's speech at the Democratic gathering in 2016 about the importance of role models for children, but really not just for children, but she highlighted children. And I just thought that was an excellent speech about why it's so important to have ethical, kind leadership, to not be a role model. And I've been reading a lot personally about anti-Semitism and European history, particularly Central and Eastern Europe. And the populations were greatly affected by what their leaders allowed. And that for many years in the Austro-Hungarian Empire, there was a real ethic of not being anti-Semitic. And when that broke down after World War II, you saw, the hell that happened, 10, 15 years later over a period of time when sort of the most negative aspects were given encouragement and fuel for, you know, behaving in very nasty ways. So I think leadership is really important on an ethical and personal level. And I think this country can change. People are not born being a racist or being, nasty in other ways. It's something that's socially developed, and it can be socially de-developed. Germans in 1958 were vastly different from Germans in 1941. It was tremendously different at a personal and ethical level. Unfortunately, they learned the hard way, country had to be leveled, but, by the end of the Second World War, but the ethical tone of a country can change. Finally, on that topic, if you think about the East Asian response to COVID, all of those countries, regardless of the tenor of their government, so the People's Republic of China, Taiwan, Korea, they all were, and Japan less so, they all wear masks a lot and they were willing to cooperate. I mean, the Chinese people put up with it especially a lot being on lockdown for so long. I mean, the end of that was handled especially poorly, that they ended it in the middle of winter. That was a bad idea. But the point is that before the policies became a little extreme more recently, those populations did not argue. They did not want to get COVID themselves, but they also didn't want to transmit it to other people. So there is generally more of a social ethic in eastern parts of Asia, including Southeast Asia, Thailand, those countries. And they, in general, as a gross generality, they were a lot more a lot more cooperative and even encouraging uh, to support each other in that way. And again, this is not in their genes. You don't get that genetically to have social solidarity, as opposed to the United States, where many politicians encourage those people who are more individualistic and kind of anti-communal in their personal ethics, and that helped to fuel the pandemic. Some research came out in the area of COVID that showed that people living in counties and states where the government had very, you know, was ethically kind of opposed to any mandates, mask mandates or anything, there was a much higher death rate. And so these kinds of things matter, but also, I mean, the point I'm making is they're not built into your genetic code. So anyway, I think the 10 states eventually will participate in the Medicaid expansion, but it's going to require activism. It won't happen on its own. The progressive elements in those states and the healthcare workers have to keep working at it. I mean, think about the civil rights effort in the United States. It was a long, long struggle. When the first civil rights activists said, what are you doing here? This is completely unacceptable. It suddenly didn't change. There was a long struggle over many, many years. And the struggle for humane healthcare system is likely to last many years too. We've got a long way to go. And other countries have mostly gotten there. You've seen drastic change in Taiwan and Cyprus. And, in Britain, they already have a universal program. Most of the other states in Europe do. They fought for it. It's not, it didn't get there by chance, by randomness. People worked really hard. So, we just have a longer way to go here in the US, but we'll get there. Okay, so this is sort of puts the last two slides together, that some of the states are very generous in how poor you have to be to qualify for Medicaid. And let me just move this out of the way. Yeah, so it turns out that for children, some of the southern states really are letting poor people get into their program. And Florida and Georgia and North Carolina require you to be really, really poor, whereas Alabama and Louisiana and Arkansas have allowed and Virginia have allowed poorer kids to get into their program. So is West Virginia. So there's a lot of variability in how these go, even though you think of a lot of these states in the Southeast as being anti-government and, conservative. The variability there, the fact that some states at least wanted to get their kids covered, that was a result of people who worked really hard to make it happen. And they've done it. And we can keep working at it over the coming years. So, but the net effect of both expansions, the percentage of the population in Medicaid has two big factors that affect it. One is the expansion of government programs. So the child health program that was initiated in 1995 or 1996 got more kids involved. It took a while for them to enroll. So you saw the increase between, around the year 2000, even though it was a very wealthy period, the economy was very strong until 2001. But the other big factor, and then Obamacare with the Medicaid expansion got a lot more people into the program. But also economics really matter. That when there's a recession, more people are losing their jobs and are poor, the Medicaid rolls rise. But as you can see, due to the long-term trend of income polarization, that we have more very, very wealthy people and more really poor people struggling with multiple jobs in households. This is going to add to the Medicaid rolls too, because so many people are just really poor. So jointly funded by the federal government, matches state spending, as I already told, with a formula. So Vermont gets 56, we're at 56%, Mississippi 72. This is the details. So Mississippi, the darker color, they get a higher match than New York, Connecticut, and the four wealthier New England states get a high match. And Maine is a little poor, and we're the poorest of the New England states, and same goes for the rest of the country. Wyoming, Colorado, California, Washington, these are wealthier states. And Alaska's got all that oil, so they're wealthier. Virginia has a lot of lobbyists who just are very wealthy and around Washington, so they end up being a wealthy state. So they get a lower match, whereas these poorer states get a higher match. Anyway, so Medicaid reimbursement to doctors and hospitals is poor. This is an important slide we went over last week. Doctors and nurses know that people insured through the Medicaid program are poor. The Medicaid card gets you access to really great, to all kinds of care without any co-pays. So there is some patients insured through Medicaid will appear to be overusing their coverage and coming in to the ER with some minor thing, like their kid has a cold and they didn't even try to take care of it at home. So people say that, and then, it has led to a stigma. So many nurses, number 3 here, many nurses and doctors regard patients insured through Medicaid as welfare patients, treat them as such, and Medicaid managed care has not had much impact. So here's the program. It's, let me just make sure I got there. Low-income families are in. They're the majority of recipients. But these low-income families, who are as much as 80% of people insured through Medicaid, they hardly cost anything, and almost all the spending in the program are the 2 lower categories. People both under and over 65 who are very ill and poor and disabled, often in nursing homes, many of them in nursing homes, they eat up all the money in the Medicaid program. So if you didn't follow in terms of the number of people, because if you looked at the number of people, that would be the top group, the low-income families, often overrepresentation of minorities, because most of the minorities in the United States are poor, so they qualify, especially their children. But if you looked at it in a different way and said, okay, where's the money going? Then that upper group would start to become a whole lot less important. And the money is going to the lower two groups. So elderly people in nursing homes are really expensive. And those who are struggling to stay at home and have all kinds of services to keep them from having to go in a nursing home, that's expensive too. And that's where the Medicaid money goes. And a lot of middle-class people, middle-class families say, who would lose all their savings if they paid for all this home care and nursing home care. So there's all kinds of legal maneuvering that goes on to dissociate the elderly person who's now needing a lot of services from the wealth of the family. And often very wealthy people, fairly wealthy people, have really high quality lawyers. They do every step correctly, and they dissociate their own personal finance from their parents, and they get to keep all their wealth and not have to pay very much. So this is kind of I guess you could call it abuse, or but it's the structure of the program, and there's all kinds of counselors that talk to middle class families about what to do when when grandma is developing dementia or some other major issue. But a lot of the Medicaid, that's where the preponderance of the Medicaid money is going. So 1 in 5 Americans are now insured through Medicaid, and it helps 10 million Medicare beneficiaries. So there's about 70 million people in Medicare. Those 10 million people that are in both Medicare and Medicaid are called dual eligible, and they are the sickest, poorest, often the least educated population. There's overrepresentation of low educational level, and they have extraordinarily high healthcare costs. That group that qualifies for both Medicare and Medicaid. And a whole lot of the long-term care is financed through the Medicaid program, as I just said, and supports the healthcare system and the safety net. One of you, I can't remember which of you, might have been Chris, asked about whether there are any or very many federal programs that are successful, and I mentioned the National Institutes of Health, and the FDA has prevented a lot of unsafe drugs. But I think I would put at the top of that list the Community Health Center program. And you, Dr. Clarissa Ortiz, met with you the first day of the internship. That is an extraordinarily successful program that, in addition to directly providing primary care to underserved populations throughout the country, it also learns about which specialists in the area will accept uninsured patients and will accept patients insured through Medicaid. They have a financial incentive to take care of every Medicaid patient. Every patient's insured that way. So it's an extraordinarily successful program. So much bang for the buck to get primary care to those populations. It's breathtakingly successful. So, look no further than that. And that program, this has been kind of Bernie Sanders' stepchild, that he's, really been the fuel to get that passed. And when he didn't want to vote for Obamacare because he didn't like that we were using tax dollars to subsidize private insurance companies, the compromise to get his vote was to expand the Community Health Center program, and that's helped even more. So Medicaid patients are treated very heavily in these community health centers. And then it allows improved state capacity to address public health problems because they're getting a little more federal money to do so. So non-elderly adults and children with disabilities represent a lot of the spending. These graphs that show 60%, that's just people under 65. If you included the elderly people who have Medicaid coverage, they make it so that 75 to 80% is spent on people with disabilities. So here's more of the same idea, that the younger people who are poor are a lot of the enrollees, that's on the left, but the money really is in people who have long-term disabilities. So keep in mind that state finances are counter-cyclical. What that means is that when there's economic boom and the economy's strong, the states are getting more revenue and taxes. But when there's a recession, the state is going to get less revenue. When there's a recession, there's going to be more people without work who might qualify for Medicaid. So at the very time when you have more of the population needing health coverage and needing social supports, the state's revenue is down. So this leads to a major crisis of financing at the state level because states have to balance their budgets. So this is a big problem, and if you're participating in the governance of your state. But how do you deal with the fact that we're not going to be in an economic boom forever? Our economy has done incredibly well over the last several years. Really, over the last 15 years, we've had steady growth pretty much, and it's not going to last forever. And, there will be a recession sooner or later, and, we'll have the same old trouble we always do. So again, during economic recessions, this can become an issue, and there'll be more patients insured through Medicaid, and if the state can handle it, and clinicians may not accept it, and more issues with healthcare. So 70% of physicians accept new Medicaid patients, the other 30% don't. Many specialists won't see kids who are insured through Medicaid. But nonetheless, people insured through Medicaid do a whole lot better than people who are uninsured. So here, this chart compares the likelihood of having had a doctor visit if you're insured through Medicaid compared to being uninsured is a whole lot better. And being aware of hypertension and having it controlled, much more likely if you're in the Medicaid program than if you're uninsured. By the way, the authors here are Dr. Dave Himmelstein and Steffi Wilhandler. Dave is going to give the afternoon talk on measuring quality. He's done tons and tons of research along these lines, health policy research. And here also you can see that people insured through Medicaid, as opposed to not having it, much more likely to have had a mammogram screening on time, and pap smear, cervical cancer screening, to be their depression dealt with, diabetics actually taking medication, their appropriate medications, and incurring catastrophic medical costs. So all of these are vastly better than not having coverage. So despite the stigma maybe and all the, that many doctors aren't willing to see patients insured through Medicaid, it's a whole lot better than not having Medicaid coverage for yourself and your family. So the Republican Party has generally been less supportive. They haven't taken the Obamacare Medicaid expansion in many of those states that are dominated. Increased documentation requirement for proof of citizenship to make sure you're a legal immigrant. And then push for block grant funding. And to the extent that the states have power, if instead of using the usual federal match, they go to get a waiver and take the money in one fell swoop based on the prior year total budget for their Medicaid program. The federal government is allowing states to the federal government's basically capitating states and saying, okay, if you want this waiver, instead of paying you a la carte, and we'll give you 72 cents for every 28 cents you spend, which is an incentive for the state to spend more. A lot of people at the federal government who are fiscally conservative, often politically conservative too, they like the idea of not having an incentive to spend more on Medicaid, but to just level it and say, okay, we in the federal government, with your 72-cent mass, say in Mississippi, you got, $1 billion last year from the federal government for your Medicaid program. Healthcare costs may go up, and you may have more spending in future years. But from now on, we're going to give you 1.05 billion. And that's what we're going to give you from here out. So lots of luck. And the state, in other words, they're getting a little bit of a financial carrot at the beginning, but then they're level funded thereafter. And that's sort of the spirit of what they're doing, that there would be no more incentive to expand their Medicaid programs. So this is something that could use more research to find out the impacts of block grant funding for those states who have elected to get into that. So I'm going to stop here at 9:56, and we're going to break until a minute after 1. And the rest of the talk will be on the privatization of Medicaid. Okay. Yes. So now we're going to describe some of the different directions different states have taken with their Medicaid programs. 9 states have continued with the original structure of Medicaid, which is to basically fee for service. The patient insured through Medicaid goes to the doctor's office, say there's a level 4 visit or a pre-op evaluation, whatever it is. The insurance is put through and the state government pays the bill. Don't forget the state government got some federal money helping them pay that bill. We already talked about that part of it. Several of the states that use a fee-for-service system have gone out of their way to support primary care and care coordination. They may have tried to enhance their primary care reimbursement, pay for care coordination, and as we have in Vermont, additional support for mental health and substance abuse. And in those very areas, many of the progressive states, especially with the fentanyl issue that we're facing across the country, have tried to enhance their support for mental health and substance abuse programs. And that's worked out really well generally, but enhanced primary care reimbursement always pushes against the state budget because the states have to balance their budget. And because patients insured through Medicaid are poor, that's how you get into it generally. Poor people in this country in particular, generally poverty goes along with, there's a psychology to poverty too. And the United States, more than most countries, when you're looking at programs on TV where wealthy people are living it up and living the good life, and you're poor people in this country, too, much more than in other countries, tend to feel like they're a failure personally and tend to feel disempowered. So the ability of poor people, or the history of poor people advocating for themselves, is probably weaker than it is in other countries. And so there will tend to be less advocacy. And as a professional, there are situations when you will want to help people advocate for themselves, like someone who's been inappropriately lost their Medicaid, their coverage from Medicaid, or can't access, some specialists, or you just may have to do more advocacy. And this is a big area where progressive lawyers working with health facilities and doctors can really be incredibly useful to people. Anyway, so there are many situations where advocacy is important to try to improve the reimbursement, but basically states can generally get away with giving really poor provider reimbursement, which then means that many doctors and even hospitals in the state may not accept patients insured through the Medicaid program, limiting their ability to get the care they need. This is an ongoing struggle. But from the point of view of the insurance companies, I already mentioned this, that the period 1965 through 85, there was a stagnation in the growth of the under 65 working population, working in companies that could provide, they had enough revenue to provide health insurance for their employees. So they began looking for, the insurance companies began looking for other ways to make money. We already talked about one direction they took is their Medicare privatization schemes, which initially, it became known as the Medicare Advantage program, to take money from Uncle Sam, and instead of paying the doctors with it and keeping it simple, it would go to the insurance companies who would then pay the doctors. In that process, keeping a meaningful amount of that money as profit. So this was another way for them to make money, and they did. And in Medicare, they've made money very handily. But it wasn't just Medicare. They also started looking at the Medicaid programs, and in particular, states that had conservative governments who believed in the private sector might be willing to subcontract their entire Medicaid program. And under Governor Ronald Reagan, the governor of California in 1971, so here's the general model before privatization, and here's what their goal was: to insert themselves as a middleman, gleaning a little bit of profit. They would then pay the doctors and hospitals. So California under Ronald Reagan, now there's 41 states who followed that lead. And the one most justifiable motive for a state to privatize its Medicaid program is predictability, is that you make your deal with the private company, and then you know that's how much we're going to pay. However, there's a problem with that, which is that, as I already said, people are on and off the Medicaid program. And if there's a recession suddenly, then there'll be a lot more people. And that managed care company, if there's now a 20% increase in the Medicaid population, they're going to want 20% more money. So really, the budgetary predictability is not as great as the state might want. And other motives they might have had is to save money because they believe that the government's always inefficient, the private sector's always efficient. So they'll get the money and they'll use it well, and it'll save everybody money and presumably not harm the patients if you cared about that. And they always, this term care coordination is inevitable. It's ubiquitous. Every time a private sector profit-seeking company wants to intrude, as in an insurance capacity or a value-based care program, they always say, oh, we're going to improve care coordination. Those doctors never talk to each other. They don't know what each other are doing. They order all these unnecessary duplicative tests. And on the receiving end of that, I have never even one single time seen any care coordination activity of any kind in any of these programs. The exception is in Vermont, before we had our value-based care program, which began in 2013, we had a state program called the Blueprint for Health, which supported primary care by enhancing the mental health offering and funding it to some extent, so we could have mental health practitioners right on site, which is a great idea in primary care. A lot of community health centers do that. And it also gave direct funding for care coordinator positions throughout the state, maybe 15 or 20 or something like that. And that funding responsibility was transferred over to our value-based care program, which is they called OneCare in 2013. So the Blueprint no longer paid for that. It was now the ACO, our value-based care organization, that paid for it. But the only reason they did it, they got extra state money to do it that we had anyway. So how much credit they deserve is pretty dubious. Anyway, but they always talk about care coordination, but and how they would improve the quality of care I provide to my patients is pretty ambiguous, but that's the argument. In fact, you could argue with all the care denials and denials of prior authorization that the quality of care probably goes down, but that's what how they promoted themselves. And enabling more flexible benefits, maybe they cover transportation to appointments. Network management is just making sure there's a doctor in every specialty, but not too many doctors in every specialty because you're trying to negotiate down their reimbursement. And then payment schemes, they could have, come up with capitation or some, a value-based care thing where if you do too many procedures, you could make the providers lose money. So get into one of these value-based care schemes. So but this was the rationale that these private sector companies would be more nimble and, get things done more efficiently. So the dark colored states have a regular old capitated managed care scheme. Then let me get this out of the way. Sorry. Some of the states have primary care case management, like I was describing for our blueprint, where we got case managers. In addition, so they're sort of subsidizing the managed care thing with state money for primary care case management. And then the non-privatized states can have primary care case management money as well without a privatization of their program. And then 5 states just have a regular old Medicaid program. So, and the one for Vermont, what they've got up there for Vermont's is not really accurate. We do have an ACO, a value-based care thing that incorporated Medicaid, some, that coordination of care money that I was just telling you about. Anyway, but most of the states have regular old managed care programs. Let me see here. And along with the growth in the overall Medicaid population, the managed care enrollment is soaring. So there's about 79 million people in Medicaid now, or plus or minus, and 64.6 million of them by 2018, probably more now, are in managed care. So states also can implement, hold on, let's read this. Controls on the cost of pharmaceuticals. States can negotiate with pharma, and increasingly these managed care organizations will be there to try to control costs. So this I can't see. Enrollees, largest share of Medicaid spending are for dual eligible. These are the most expensive patients, and this just pointing that out. States have discretion to mandate enrollment in Medicaid managed care. Most of them do. So in other words, all this advertising for Medicare Advantage plans, that's not going on. Medicaid patients are not even told many times that they're going to be dumped into a managed care program. Though in some states, they actually have a choice of which managed care program to go into. I don't think there's any state where they can say, I don't even want to be in managed care, but in some states, they may actually be given a choice. And I'm going to say more about that in regard to California. So most states that have managed care, they mandate it. The patient has no choice, may not even know. And the states must offer a choice of 2 available plans if they want to have competition. Those that do mandate it, and the information that a lot of patients insured through Medicaid don't speak English or are not well educated, and for them to contend with the advertising from multiple managed care plans is beyond unrealistic. You could argue that having a choice in Medicare is also pretty stupid because beyond age 80, 30 to 40% of the people who are over that age have some degree of dementia. So how they're supposed to see through the slick advertising is beyond me, but this is what we're doing. Anyway, so penetration into Medicaid is growing, and here's the overall enrollment. So you can see Vermont isn't participating, Wyoming isn't either, but many states have some sort of program that is heavily, entrenched in their states. And note that if you look at who are the managed care organizations, these are mostly, but not exactly, the same ones that provide Medicare Advantage plans. So the big two for the Medicare Advantage plans are United Healthcare and Humana. But Humana, because they were making so much money out of the Medicare Advantage system, they dropped out of private insurance, they dropped out of Medicaid, and they were just going to focus on maximizing their profit they make off of Medicare. So they're out of this. They're not in the Medicaid system. On the other hand, this one up here, Centene, that's the big one, along with Anthem. And United Healthcare, which is the biggest insurer in the country, they're only somewhat less involved by comparison compared to Anthem, Wellcare, and Centene. So, or compared to what they do in Medicare, what United Healthcare does in Medicare and for younger people. So United Healthcare sort of does all the groups, whereas these top three are heavily into getting into these to various states' Medicaid programs and making money in those programs off of those programs. So on the left side, you can see that 38% have very localized plans that are within their states. Some of them are a little more responsive to the medical community. They're sort of more endogenously developed, but the ones on the right, which are in packaged national plans, less so. They just do what they do, and you take what you get. So that's sort of who provides this managed care coverage. And you can see now that there's a whole lot of money in Medicaid managed care throughout the country, and many states, both red and blue, are involved in subcontracting their Medicaid programs. So it's pretty profitable. So the amount of money the state is paying is greater than the amount of money spent on getting care for the population. Now, if you look at the profitability for the different groups within the Medicaid population, AFDC and GA, $7 per member for AFDC and GA. These are the programs for younger people who are very poor. And they don't cost very much, so not much money goes into them. A lot of it is pediatrics, outpatient pediatric care. It's just not that expensive. So they make money. They make, $7 per member per month out of AFDC and general assistance. They make more money in the disabled population, but the disabled people over age 65 or who are so disabled that they qualify for disability in the Medicare program, because Medicaid and Medicare both have criteria to accept disabled people. Very complicated bureaucratic complexity, but basically your disability can get you into both programs if you're Medicaid if you're poor, and Medicare if you're just pretty disabled and don't have too many assets. Anyway, these people are incredibly sick. They have lots of health problems, lots of money going through there. And these insurance companies make a whole lot of money on the dual eligible population. And, very sick people, and the state's losing a whole lot of money in siphoned off as profit. Also, their accounting tends to be pretty cloudy compared to the federal players. Some of them mix Medicaid, managed care organization financial data with their commercial plans, and this has been audited and found to be a big problem. And the states have trouble negotiating prices and working on accountability because state governments are often pretty small. And they're often kind of a financial black box. So it's sort of a money tree for them, but it's pretty hard for states to know what to do. And just to say this, for this reason, speaking of a coalition between progressive health law people, lawyers, progressive lawyers, and doctors, the state of Connecticut, in the state of Connecticut, they got a coalition of progressive lawyers and doctors together to deconstruct their Medicaid managed care program. And they got rid of it after it had been in place for several years. And the state saved money, and the patients, by all measures, they got better care. We have an activist within PNHP who's would be able to talk to you more about that. But anyway, so yeah, in the state of Connecticut, they ousted their managed care. So so there's a lot of variation in overhead for these private insurance subcontractors. 37% point spread in Medicare loss ratio, which is the percentage of money out of their overall money that's going through, how much of it gets spent on medical care. So a company that has a 114% medical loss ratio means the amount of revenue they took in was less than the amount of money they spent on medical care. And you can't, that's not viable. You have to have a fund reserve, and they're going to deplete their fund reserve because they spent so much money on medical care. But that's not the rule. Most of them are averaging. I think the average for the Medicaid managed care is 87%, meaning 13 cents of every dollar that the state gives them is retained, either used to pay for their administrative employees or a profit for their investors. Never goes to medical care. So, and there's a huge variation in insurance reserves. Insurance companies have to have financial reserves in case they have a bad year or there's a pandemic or something happens. So there's a lot of variability. This needs to be regulated because it just needs to be regulated so that they can pay their claims in a bad year. And the administrative costs for state Medicaid, which should have gotten rid of their administrative costs because they've dumped all the administration of the program onto these managed care organizations, but actually it doesn't do that much. They have to, for one thing, they have to watch over the Medicaid managed care organization, which is trying to make a profit. So that's one way that program goes. But also the Medicaid programs are working on eligibility, who's really qualified for the program, because so many patients are on and off. So, and there's Medicaid's a big complicated program, so it didn't even help very much with reducing their administrative burdens. State share of Medicaid in general is about 15 or 20% of total state general funds. So how much of that is wasted on this privatization scheme? Hard to know. So now if you look at the care that the patients get, here's one statistic. This is every year. This never varies. That the privatized Medicaid deny a much higher percentage of claims than the Medicare Advantage privatization actors. And why don't you guys guess why that might be?
I'm gonna assume this is the way they make money, correct? Dr. Malik, I was gonna ask you, it's unclear to me how they're making a profit. Like what is being streamlined by the managed care organizations such that they can be making a profit, but I suppose it could be because they're better at denying care.
Oh, there's many, many, many more care denials for sure. And also they negotiate high. I mean, the negotiation itself, they can say, well, you spent, 100 million last year in your Medicaid program. Costs are going up. We need an adjustment period, so why don't you give us 110 million? It's just so also in the negotiation itself. And then they have their usual schemes, which we've already learned about, and this is one of them, denial of care. But one of the ways they get rid of this is because the patients insured through the Medicaid program are poor. In the United States, that pretty reliably translates into disempowered. So the percentage of people who appeal these denials is really low. It's 0.1%. 1 in 1,000 get appealed. And so, and they don't have a lot of these patients don't have access to the legal profession to support them in appeals for the most part because they're so poor and, what are they going to pay with? So they get away with very high denial rates. a lot of elderly people aren't going to put up with that. And so, you know, the Medicare Advantage history on the Medicare side is it started out kind of as a white middle class suburban program. And now Medicare Advantage has changed and it's become more catering to poor people, which is going to have a lot of implications. But, you know, white middle class people have much better access to lawyers and to the ability to, you know, appeal a claim than, you know, a linguistic minority person who's, you know, insured through Medicaid. So anyway, so I mean, you can use your imagination there. You can get away with fleecing these, you know, with getting away with this because the state may not care very much. The patients are not likely to fight. So, you know, the only way to counter this is through effective advocates. You know, you can call, you know, the conservatives might call them bleeding heart types, but you know, this is for many of these people, this is life and death. Just the way it is. So denials by Medicaid managed care, 2.7 million enrollees in Medicaid were in plans that denied more than 25% of all prior authorization requests. Imagine that. I mean, do they think these doctors are idiots for ordering these tests? It's just appalling. As I said, only 1 in 1,000 are appealed. And they did a study of appeals of denials by income, and they discovered I think every 25% increase in the family income leads to a substantial a big increase in the likelihood of an appeal going on. So poverty is associated with just taking what they'll give you rather than fighting back for your rights, really. So Hawaii converted their fee-for-service Medicaid to a managed care in 2 steps. The doctors faced a lot of increasing administrative hassles, so doctors started to drop out. This worsened access, and this turned out to be especially true for mental health. Despite this whole managed care thing, their cost increase to the state was 3% higher than the U.S. average for the period studied here, which was 2001 to 14. And then finally, they were particularly oppressive to mental health providers, making them explain why they wanted 5 more visits for a person with severe depression or, you know, whatever it is they're treating. So by 4 years after they managed careized their Medicaid program, including mental health, more than half the psychiatrists dropped out. And mental health related hospital costs increased by 30%. So this is what can happen. But you know, a lot of these are delayed, like managed care contracts get renewed year to year, and the patients may select a different managed care organization. So for them to deny care now might put the cost of a hospitalization on someone else later. So, you know, the play on and off of health insurance plans gives these plans a temptation to deny care. So this all was documented by the Kaiser Family Foundation. Anyway, Medicaid managed care patients have trouble getting appointments, so there's narrow networks. So this is the Inspector General of Health and Human Services, because some of this information actually made it up to the Center for Medicaid and Medicare, the wing of that oversees Medicaid, and there was effective enough advocacy by some health advocates that they actually persuaded the Medicaid bureaucracy in Washington to study it. And what they found when they did this big study in 2013 and 14 is that the managed care, I'm sorry, I just got backwards. Okay, is that 8% of the patients who are trying to get an appointment called someone who won't take any more patients from that plan. Another 43% were not even really participating, but they were on the list of providers that the patients got. And they weren't even in the plan, at least not that year. 26% were offered an appointment within 2 weeks, which was the goal. because a lot of this is primary care. And another, just lost the slide again, sorry. Another, what percentage is here? 24% were offered an appointment, but it wasn't within 2 weeks. So this was an important study by the Office of Inspector General of Health and Human Services. And this was discouraging. So this is another strategy that managed care organizations can use to assure their profitability, is to narrow their networks. I don't know if they intentionally put out misleading lists that aren't even accurate of who's on their list. I'm in no position to comment on that. But I mean, those were the results of the Inspector General report. So anyway, they can have a narrow network. And the big strategy, the biggest one of all, in my experience, is not even something we talked about, which is in an urban setting where there's multiple hospitals. In Albany, New York, where I worked and was involved in a situation with managed care plans, the plan that had the most enrollees in the eastern side of Albany excluded the hospital on the eastern side of Albany from their list of hospitals that were in network. And the patients had to go all the way to the other side of town to a hospital, which they couldn't do in an emergency. And I mean, you can imagine the implications of this, how many people, we had a lot of linguistic minorities. We had a lot of patients from Afghanistan and Vietnam then. And, they were not necessarily going to the right hospital and might not have understood the information that the plan gave them. So, this is another big scheme, is don't make it geographically difficult for patients to access care. That strategy is not used very frequently by Medicare Advantage plans, which have to provide better care or they're going to get complaints, more likely to get complaints. But in Medicaid, you can get away with a lot. So, and my final one here, the state of California California's the most populous state in the country. And I already talked about Connecticut. Oklahoma also jettisoned their Medicaid managed care and were better off financially. I don't know the story of Oklahoma, so one of you can look into that if you're interested. California, the Medicaid program is regionalized because it's a huge state. And all the regions adopted managed care after Reagan required it in 1971. But they had two different models they were using. One was to have a single managed care organization for all the Medicaid insured patients in their subregion of California. But others allowed there to be competition among plans. And they studied it after a while, and what they found was that regions that selected a single managed care organization, essentially subcontracted the entire Medicaid population, experienced better access to care and lower costs. So that's kind of interesting, and this has been proposed by some single payer advocates, potentially even for a national plan, that you could kind of try to, even though it's a single payer, because you could potentially have a single payer system where you subcontract to a single payer to include the whole country. You could do that. I wouldn't advise it, but it's been proposed to make it sound like it's not Stalinistic, and used to make it sound better. And that was proposed here in Vermont when there was a flurry of pro-state-based single payer activity. They imagined that we would subcontract much of the administration to our local Blue Cross plan. Anyway, but the idea was this plan, the regions of California that had a single plan may have felt more invested in their population, figuring that if they did a good job, their contract would be renewed, as opposed to a competitive model where competition among insurance companies leads to just trying to get profitability as long as you can, denying benefits, giving misleading information to their employees. It's more of a scramble. And there was many more denials of care in the competitive area than there was in the one with a single entity. I thought that was pretty interesting in terms of, lessons for health policy.